Orthopedic Surgery, Part 2, Chapter 3, General Principles of Joint Injuries. Joints are complex structures composed of bone ends covered with smooth hyaline articular cartilages held together by strong ligaments and capsules. Joints usually contain fibrocartilaginous structures such as the menisci in knee and labrum in hip and shoulder, interposed between the articulating surfaces, performing different functions. Joint injuries result in variable degrees of harms to these structures, leading to pain and loss of function. Joint dislocation, subluxation, and fracture dislocation. Definitions: dislocation implies that joint surfaces are completely displaced and no longer in contact. Subluxation implies that lesser degrees of displacement, such as the articular surfaces, are still partially opposed. Fracture dislocation is a severe injury in which the joint dislocation and usually intra-articular fracture on one side have taken place simultaneously. Etiological types of dislocation. Dislocation is usually caused by high-energy trauma. However, in exceptional cases, dislocation may occur during the normal range of motion. So we have traumatic and habitual or voluntary dislocation. Traumatic dislocation, high-energy direct trauma, results in forceful displacement of one articular surface after tearing of the joint stabilizers such as ligaments, fibrocartilages, and capsule. If the ligaments and joint margins are damaged, repeated dislocation may occur with lesser degrees of trauma, and it's named recurrent dislocation. This is seen especially in the shoulder and the patellofemoral joints. Habitual or voluntary dislocation. Some patients acquire the knack of dislocating or subluxation the joint by voluntary muscle contraction. Ligamentous laxity may make this easier, but the habit often betrays a manipulative and neurotic personality. It's important to recognize this because such patients are seldomly helped by operation. Clinical features and diagnosis of traumatic dislocation. Following an injury, the joint is painful, so the patient tries at all costs to avoid moving it. Look for the shape of the joint; it's abnormal. The bony landmarks may be displaced. Limb is often held in a characteristic position such as shortening, flexion, adduction, and internal rotation in posterior hip dislocation. Feel and move. Severe tenderness and limitation of all movements. Checking for neurovascular status of the limb is essential. Special test. If the dislocation is reduced by the time the patient is seen, the diagnosis may be in doubt. This is where the apprehension test is useful. The joint is slowly and cautiously moved to reproduce the dislocation. The patient apprehends, develops a sense of impending disaster, and violently resists further manipulation. Radiology and imaging. X-ray will usually clinch the diagnosis. Disruption of the standard joint lines and articular surfaces congruity, an associated bone fracture affecting joint stability in fracture dislocation. CT scan is helpful to delineate associated bone injury as intra-articular fractures or impactions. It's also indicated after apparently normal radiographs with limited ranges of motion to avoid commonly missed posterior dislocations of the hip and the shoulder. MRI is used to detect the associated soft tissue injuries as displaced labrum or torn ligaments. Treatment. Closed reduction of the dislocation may be made as soon as possible on an urgent basis to avoid prolongation of the period of the stretch of the neurovascular structures, as well as to minimize pain and damage to the intra-articular structures, usually under general anesthesia and muscle relaxation. The key step is traction to relax the associated muscle spasms and unlock the fragments, followed by reversal of the dislocation position. Open reduction is indicated if the closed trial is failed and the associated bone fracture renders the joint unstable and needs fixation. Reduction is followed by rest and immobilization until the soft tissue stabilizers heal from 2 to 3 weeks, and this is followed by physiotherapy and rehabilitation. Surgical reconstruction of the stabilizers is indicated if the joint remains unstable. Ligament injuries. Ligament sprain or tear. It occurs when the joint is momentarily twisted or bent into an abnormal position. Ligament sprain refers to the overstretch or the tear of some of the ligament fibers, but the outer shape remains intact and the joint remains stable. May range from mild to severe degrees. Clinical features and diagnosis. Variable degrees of localized pain and tenderness. Variable degrees of localized swelling and or bruising according to the degree of injury. Stress test by stretching the injured ligament causes sharp pain, but no abnormal joint mobility. This is the endpoint. Radiographs is usually done to exclude fractures or cracks. Treatment. Initial firm strapping and a short period of rest, ice, compression, and elevation for a few days until the acute pain and swelling subside. As soon as the acute inflammation subsides, early movement and rehabilitation exercises are encouraged. This is very important to encourage proper fibers healing and function restoration, preventing chronic sprains, pain, and laxity. Ligament rupture, a severe injury leading to a complete tear of the whole ligament fibers and structure, making the joint unstable. Hinge joints, the knee, ankle, fingers, and thumb, are more susceptible. Clinical features and diagnosis: the patient usually reports a sudden snap or click, followed by severe pain and inability to move or weight bear. Considerable bruising and joint swelling occur immediately. Hemarthrosis may be detected in cases of intercapsular ligament rupture, such as anterior cruciate ligament. Movement examination usually shows joint instability, subluxation, and abnormal mobility, usually under general anesthesia. X-ray may show detached flake of bone if the ligament is avulsed rather than torn. This is called avulsion fracture. MRI, the investigation of choice. Treatment: most ligament ruptures can be treated non-operatively, initially by measures to control pain and acute inflammation, complete rest, immobilization by splints, and rice. Tense hemarthrosis should be evacuated, aspirated, or drained. After 1 to 2 weeks, the splint should be replaced by a functional brace, which allows physiological joint movements and at the same time prevents further injury. Early physiotherapy and rehabilitation are encouraged. Surgery in the form of repair or reconstruction is indicated in special situations, such as ligaments which don't heal spontaneously, as the ACL or PCL of the knees, anterior cruciate or posterior cruciate ligaments of the knees, or if residual instability persists. Specific injuries to common joint structures: meniscal injury. Medial and lateral knee menisci are C-shaped. Medial and lateral knee menisci are C-shaped fibrocartilages which distribute load across the joint surface. Mechanism of trauma: usually knee twist in variable degrees of flexion. Degenerative tears can occur with minimal or no trauma in elderly. Clinical features and diagnosis: torn menisci may cause pain, effusion, and locking, incomplete knee extension. Examination may reveal joint line tenderness, effusion, incomplete extension. MRI, the investigation of choice. Treatment: conservative, muscle strengthening, and lifestyle modifications reserved to minimal symptoms and low demands in elderly patients. Arthroscopic repair or meniscectomy, partial or total, is considered the gold standard. Cruciate ligament injuries: anterior and posterior cruciate ligaments originate from the intercondylar tibial area anteriorly and posteriorly, inserting into lateral and medial femoral condyles respectively. Resists anterior and posterior translation of the tibia over the femur to maintain stability. Mechanism of trauma: ACL or the anterior, usually twisting injuries, while the posterior, usually direct applied force from anterior to posterior, such as dashboard. Clinical features and diagnosis: acute, pain, swelling, popping sound, difficult movement, chronic, recurrent effusion and giving away. Special tests to detect excessive anterior or posterior translation, anterior and posterior drawer tests for ACL and PCL respectively. MRI, the investigation of choice. Treatment: conservative, muscle strengthening and lifestyle modification reserved to minimal symptoms and low demands in elderly patients. Arthroscopic reconstruction is considered the gold standard. Chapter 4: Special injuries. Fractures in children. Immature growing bones have different characteristics than adult ones. Soft and less brittle, usually bows or buckle instead of breaking, covered by thick periosteal and endosteal layers, rich in stem cells with high repair and remodeling power. At each end of the long bone, a precious cross-cartilaginous plate is called epithelial plate exists. These factors make the pediatric fracture unique and need special attention. Due to the importance of the gross plate, we can broadly categorize pediatric skeletal injuries into physeal and other bone injuries. Physeal injuries are common in children, represent 15 to 30% of all bone injuries. The physis is formed of cartilaginous disc or gross plate, which is responsible for the longitudinal growth of the long bones. It represents a weak area separating the epiphysis from the metaphysis. Types: any injury passing through a part of the whole gross plate is included. 5 injury types are well known according to Salter-Harris classification. Type 1, transverse fractures through the whole plate. Type 2, transverse fractures through a part of the plate with extension to the metaphysis. Type 3, transverse fractures through part of the plate with extension to the epiphysis. Type 4, vertical fracture through all 3 regions, metaphysis, physis, and epiphysis. And Type 5, crushing injury of a part or the whole gross plate. Management diagnosis follows the general principles of fractures. However, high index of suspicion is required to avoid missing this injury. Special attention should be given for minor swelling and tenderness may be the only presentation at the ends of the bone, especially in non-displaced type 5. Minor displacement can be misjudged as apparently normal gross plate. Therefore, Comparison views with sound side or oblique views are often required. Physio injury must be treated as soon as possible on an urgent basis as it quickly becomes sticky and units. This also prevents further gross plate damage. Reduction and fixation should be gentle to prevent additional iatrogenic injury to the stem cell in the cartilaginous plate. Anatomical reduction is the goal. If not possible at the first closed attempt, open reduction should be considered promptly. Rigid staple fixation is the goal, usually done by K-wires or screws. The most common complication is gross disturbance, complete gross arrest of the physis or incomplete arrest, leading to angular deformities or limb length discrepancy. Then we have other bone injuries. Children's bones are soft and usually don't fracture completely. Different pattern of incomplete fractures occurs instead. The most common two types are bucking due to compression injury and green stack fracture due to tension or bending injury. Since these fractures are often caused by low energy trauma, fall from a chair, minor signs and symptoms usually exist. Injured infant usually presents with dead limb. The cellular activity during the healing process is much higher in children, and this results in a much quicker healing, as well as very rare incidence of non-union. During growth, bones in children undergo considerable remodeling, and therefore a malunited fracture in a child could remodel completely to a normal or near normal shape again. This is more evident in the younger children and the nearer the fracture to a joint. Depending on the high and rapid remodeling power, wider ranges of functional reduction acceptance are allowed than in adults. This depends on the age and location of the fracture. Most pediatric shaft fractures could be treated conservatively in the form of closed reduction and plaster immobilization. Many recent trends in management are more inclined towards using minimally invasive techniques such as K-wires and flexible intramedullary nails. Fractures of the spine. The vertebral column is a complex osteocartilaginous ligamentous structure. Spine stability is dependent on the integrity of bones and ligaments. Accordingly, fractures or fracture dislocations or dislocations may occur. Injuries of the vertebral column tend to cluster at the junctional areas, occiput to C2 or C7 to T1 and T11 to L2. These areas represent stress concentration regions where a rigid segment of the spine meets a more flexible segment. Mechanism of injury, typically high energy trauma in a polytraumatized patient, such as motor vehicle accidents fall from height, and less commonly, pathological fractures, metastasis or infection, insufficiency or fragility fractures, VCF due to osteoporosis. Classifications according to fracture pattern: stable and unstable, stable, wedge, compression, avulsion, unstable, any translation in the coronal or sagittal plane, and or more than 50% loss of vertebral height. According to neurology, intact and neurological affection incomplete or complete. Clinical evaluation follows the general principles of a fracture. However, certain points must be stressed upon, including ascertain the patient's history, query for the mechanism of injury, witnessed head trauma, movement of extremities, and the level of consciousness following the trauma, evaluation of the level of consciousness using Glasgow Coma Scale, evaluation of head, neck, chest, abdomen, pelvis, and extremity injuries. Any patient with head injury, especially unconscious, should be considered to have a neck injury with ensuring cervical clearance. Associated orthopedic injuries, calcaneal fractures in falls from a height. Neurology examination is an integral part of the spine fracture assessment. Radiological evaluation, X-ray evaluation is critical. Adequate cervical X-ray must show the occipito-cervical junction, all 7 vertebrae as well as the cervicothoracic junction from the base of the skull till T1. Adequate lumbar X-ray must show the thoracodorsal spine, all 5 lumbar vertebrae as well as the lumbosacral junction from T12 to S1. Assessment follows the ABC rules. A. Adequacy. Junctional areas are seen. A. Alignment. Anterior and posterior longitudinal lines are continuous and uninterrupted. Bone. Equal anterior and posterior heights. C. Cartilages. Equal spaces. Any deviation from the normal shape should alert the physician to a problem. CT scan is mandatory for proper evaluation of the mechanical stability and canal compromised by the fracture fragments. MRI is used for soft tissue evaluation, especially the discs, spinal cord, and nerves. Treatment on site. When the fracture of the spine is suspected, movements must be prevented. Cervical collar, head immobilization, and using a stretcher to move the victim in one piece. In the resuscitation room, ABCDE concept, using of intravenous methylprednisolone in patients with neural deficits. Stable fractures, conservatively treated by rest and immobilization by cast, brace, or collar. Unstable fractures operatively treated by internal fixation with or without decompression according to the neurological status. Care of patients with neurological deficits, ileus aspiration, and hemorrhagic gastritis are common early complications. Urinary tract infection is a recurrent problem in a paralyzed patient. Quadriplegic patients can inspire only using their diaphragm because their abdominal and intercostal muscles are paralyzed. Skin pressure ulceration is common owing to anesthesia of the skin. Clearing the spine. A cleared spine in a patient implies that proper spine evaluation is complete and the patient doesn't have spinal injury requiring treatment. Criteria for clinical clearance of cervical and thoracolumbar fractures are: patient is awake, alert, non-intoxicated, no other distracting injury, the patient has no neck pain, tenderness, or neurological deficits. The process of clearing the thoracolumbar spine is like that of the clearing for the cervical spine. Only anteroposterior and lateral view radiographs are necessary. Fractures of the pelvis. The pelvis is another example of a complex osteocartilaginous ligamentous structure. Its ring structure made up of the sacrum, two innominate bones held together with very strong ligaments. Pelvic stability is dependent on the integrity of bones and ligaments. Accordingly, fractures or fracture dislocations or dislocations may occur. Mechanism of injury. Typically, high energy trauma in a polytraumized patient, usually grossly displaced, associated with other serious injuries, may be life-threatening. Mortality rate 1 to 15% for closed fractures and much as 50% for open fractures. Less commonly, pathological fractures such as metastasis or infection, insufficiency or fragility fractures, BCF, due to osteoporosis. Classification. Fracture displacement can only occur with disruption of the ring in two places: stable, partially unstable, and completely unstable. Stable fracture include fractures not involving the ring, such as avulsion or iliac wing fracture, or minimally displaced fracture of the ring. Partially unstable, rotational unstable but vertically stable, including unilateral hemipelvis external, open book, or internal rotation or combined bucket handle injuries according to direction of the trauma. Completely unstable, rotational and vertically unstable, including complete disruption of the pelvic ring leading to vertical and rotational displacement. Clinical evaluation. Follow the general principles of the fracture. Look may reveal abnormal lower extremity positioning, limb length discrepancy, scrotal, labial, or perineal hematoma, swelling or ecchymosis, flank hematoma, or lacerations of the perineum. Feel. It reveals tenderness over the pelvic region. Moving the pelvis to test for instability should be done gently and once to avoid disruption of the intrapelvic hematoma. Associated injuries should be examined and ruled out. Urogenital exam, vaginal and rectal examinations to rule out occult open fracture. Lumbosacral plexus injuries L5 and S1 are the most common. Radiological evaluation. Pelvis anteroposterior X-ray view is a part of the initial atlas evaluation and reveals almost 90% of the injuries. Checking for the integrity of the pelvic ring is key for injury detection. Look for asymmetry, rotation, or displacement of each hemipelvis. CT scan is mandatory for detection and evaluation of occult fractures as well as posterior ring fractures. Associated injuries. Hemodynamic instability may be a killing fracture from excessive intrapelvic bleeding. Common sources of hemorrhage. Venous injury, 80% of the cases due to tearing of posterior thin-walled venous plexus leading to retroperitoneal hematoma up to 4 liters of blood, bleeding cancellous bone. Uncommonly arterial injury, and this is 10 to 20%. Urological injuries, higher incidence in males, includes posterior urethral tear, most common, and or bladder rupture, hematuria, or bleeding at meatus, or high riding or excessively mobile prostate may be suggestive of injury. Diagnosis is made by retrograde ureterocystogram. Neurological injury, lumbosacral plexus injuries L5 and S1 are the most common. Treatment. Initial management in cases of hemodynamically unstable fracture pelvis include the patient resuscitation together with fracture stabilization and controlling the source of bleeding using external fixation, pelvic binder using simple bed sheet or prefabricated device, angiography, and immobilization. Definitive management depend on the fracture stability. Stable fracture patterns require only bed rest and immobilization, while unstable fracture patterns require open or closed reduction and internal fixation. Fractures of the hip. Fractures around the hip joint, mainly proximal femoral fractures, constitute large burden on the health systems worldwide in its bimodal age distribution, in young adults due to high energy trauma having high morbidity rate, and in the elderly due to low energy trauma having high mortality rate. Classification. Anatomically, the proximal femoral fractures are classified into intracapsular and extracapsular fractures due to the anatomical variation between the two parts. Intracapsular part, neck region, carries a peculiar blood supply to the femoral head. Fractures lead to avascular necrosis, AVN, of the femoral head and consequently secondary osteoarthritis. Intracapsular part lies inside the joint with synovial fluid rich in fibrinolytic enzymes preventing fracture hematoma organization, leading to delayed fracture union or non-union. Intracapsular part coverage is devoid of the periosteal layer, weakening its healing ability. This is totally different from extracapsular part, which is the intertrochanteric region, which is rich in blood supply and periosteum. Diagnosis. Usually the patient represents with inability to weight bear on the affected side, with pain in the groin region. Clinical examination reveals the classical position of external rotation, abduction, shortening together with tenderness. Hip anteroposterior and lateral radiographic views are diagnostic. CT scan or MRI may be useful to detect occult fractures, negative radiographs, but physical examination is consistent with the fracture. Subclassifications. Intracapsular fractures are categorized into displaced and non-displaced. Displaced type is more liable to complications, non-union, and AVN, while the extracapsular fractures are categorized into stable and unstable. Unstable, more than 2 fragments, comminuted type, is more difficult to treat and more liable to re-displacement after fixation. Treatment. Urgent surgical management is needed in young adults to preserve blood supply, prevent further damage, in elderly to avoid complications of prolonged recumbency. The choice of treatment depends on many factors including site, type of the fracture, and type of patient. Intracapsular fractures in young adults require urgent anatomical reduction and rigid internal fixation. This will provide the best environment for union and prevent the possibility of complications, preserving the patient's native hip. Intracapsular fracture in elderly require early hip replacement, whether by heme arthroplasty HAP, or total hip replacement THR. This will allow immediate ambulation and avoid complications of recumbency. Extracapsular fractures tend to heal fast with low healing complications. The treatment of choice in all age groups is proper reduction in internal fixation. This will allow preservation of the native hip in young and early mobilization in elderly. Complications of bone and joints injuries, Chapter 5. General complications. General complications refers to the problems which may arise from distant tissue damage, hemorrhage and shock, fat embolism, muscle damage and rhabdomyolysis. Prolonged bed rest and immobilization cause chest and urinary tract infection, pressure sores and muscle wasting, deep vein thrombosis and pulmonary embolism. Hemorrhage and shock. Hypovolemic shock may accompany major fractures as the pelvis or the femur. However, it's imperative to remember that the fractured patient may have multiple injuries and shock may occur from associated injuries in the abdomen or chest. Fat embolism syndrome, rare but severe condition which may follow major long bone fractures where multiple small fat emboli from the bone marrow enter circulation from the fracture site. Diagnosis is essentially clinically presenting with one or more of the following: anemia and thrombocytopenia, pulmonary embolization, respiratory distress and hypoxia, cerebral embolization, agitation, delirium, and finally coma. Petechial rash only present in 1/3 of the cases. Treatment is basically supportive. As there is no direct treatment, the best way is to avoid it by early fracture reduction and stabilization. Muscle damage and rhabdomyolysis. Rhabdomyolysis is a condition which occurs when skeletal muscle is rapidly broken down, releasing myoglobin into the circulation. This is usually seen in severely neglected cases of compartment syndrome. Chest and or urinary tract infection, common complications due to prolonged immobility, especially in the elderly. Elderly are at high risk of hospital-acquired pneumonia. This tends to be very serious as the causative organisms are often more resistant to antibiotics. Urinary tract infection is common due to castorization. This should be avoided by early castor removal as soon as possible following surgery. Pressure sores and muscle wasting. Pressure sores and ulcers due to tissue ischemia from prolonged pressure, usually over the bony prominences of the skull, sacrum, and heels. The key to prevention is careful nursing and early mobilization. Muscle atrophy and wasting for another problem of immobilization and should be prevented by early physiotherapy and mobilization. Venous thromboembolism. DVT, is the most common serious problem in orthopedic surgery. Moreover, fatal pulmonary embolism is considered the primary cause of mortality. The Virchow triad is usually present in fractured or dislocated patients. VTE, or venous thromboembolism, commonly occurs around the day 6 post-injury. High index of suspicion in any orthopedic patient with unilateral leg swelling or whose clinical condition acutely deteriorated. All orthopedic patients not capable of mobilization should have multimodal prophylaxis against VTE or venous thromboembolism. Local complications. Local complications refer to the fracture-specific complications. They are divided into immediate, early, and late. Immediate, skin, vascular, neurological, and visceral injury. Early, compartment syndrome and infection. Late, recurrent instability, malunion, delayed and non-union, avascular necrosis, complex regional pain syndrome, gross disturbance, myositis ossificans, and finally joint stiffness. Skin injury. The fractured bone ends may injure the skin from inside and turn this fracture into an open one with higher risk of infection. Vascular injury. The fractured bone ends may injure or compress the adjacent vessels. Common examples: injury of the brachial vessels following supracondylar fracture of the humerus, and injury of the popliteal vessels after supracondylar fracture of the femur. Management should include removal of any compression badge or cast, prompt reduction of fracture, re-evaluation of the vascularity. In cases of arterial injury, fracture, rapid reduction, and rigid fixation are performed prior to the vascular repair. Neurological injury, adjacent nerves may be injured, whether by excessive traction or compression, leading to neuropraxia, axonotmesis, or less commonly by being torn, neurotmesis. Common examples: radial nerve injury with fracture shaft of the humerus, and common peroneal nerve injury with fracture neck of fibula. Spine fractures may lead to whether central or peripheral neurological deficit according to the fracture location. Visceral injury, pelvic fracture carries high incidence of visceral injury, with the bladder and urethra being the most at risk. Care should be taken with catheterization when the blood is seen at urethral meatus. Compartment syndrome, the commonest sites are the leg and the forearm, though it can occur in anywhere with myofascial closed compartment. Infection, usually seen with open fracture and post-operative infection, leads to delayed healing, non-union, or osteomyelitis. Recurrent instability due to tearing of the joint stabilizers at the labrum in the shoulder and ligaments in knee and elbow. Malunion, defined as a fracture union in unacceptable position, leading to deformity which affects the function due to inadequate reduction. In children, malunion could be more acceptable than adults, as the power of remodeling with growth is high. Delayed union and non-union. Delayed union, the process of healing is delayed, however, the bone ends are still active and there's still a chance for union with prolonged uninterrupted immobilization. While non-union, the total arrest of union process, the bone ends are sclerosed and the fracture gap is filled with fibrous tissue. Clinically, presents with tenderness, abnormal movement at the fracture site. Several general and local reasons exist affecting whether the mechanical stability or the biological environment of the fracture. The exact cause should be identified and treated to restore the union process. AVN, or avascular necrosis of the bone. Certain fractures may damage the blood supply to the adjacent bones, leading to avascular necrosis. Common example: intracapsular fracture of the neck of the femur may lead to AVN of the adjacent head, leading to loss of the head spherical contour and secondary hip joint osteoarthritis. Gross disturbance. Fractures affecting the gross plate in children may lead to gross arrest. This may lead to deformity or limb length discrepancy. Complex regional pain syndrome, CRPS, a syndrome of exact unknown pathology, commonly known as Sudek's atrophy, clinically characterized by pain, swelling, joint stiffness, as well as changes in the surrounding skin color and moisture, radiologically characterized by severe osteopenia of the affected area, commonly seen after wrist, hand, ankle, and feet fractures. Primarily occurs due to post-fracture immobilization due to casting or reluctance of the patient to use the limb after the operation or after removal of the cast. Difficult condition to treat and considerably disabling. Treatment is basically aggressive physiotherapy immobilization. Prophylaxis is fundamentally by early mobilization of all non-fixed joints while in cast and post-operatively. Heterotropic ossification and myositis ossificans. It's the ossification of the hematoma or adjacent muscles. Ranges from minor non-significant ossification to complete joint ankylosis, commonly after dislocation of the elbow, shoulder, or hip, especially if aggressive passive mobilization is practiced in rehabilitation. Joint stiffness and secondary osteoarthritis. Stiffness is caused by intra-articular adhesion. surrounding soft tissue fibrosis, and contractures due to prolonged immobilization. Secondary osteoarthritis follows a malunited intra-articular fracture leading to joint surface irregularities, and this concludes our part for the orthopedic surgery for today.